afternoon everyone. I am Dr. Tarang Shah. I am working as an assistant professor in Cardiology department of UNMICRC Institute of Cardiology and Research Department. Today we are going to discuss about Takotsubo cardiomyopathy. So outline of today's discussion will be definition, epidemiology, what are the triggers and risk factor, pathophysiology, clinical presentation, diagnosis, and in the end we will look for the management. So definition of Takotsubo cardiomyopathy. It is a clinical syndrome characterized by an acute and transient, which is less than 21 days, left ventricular systolic dysfunction mainly, often related to an emotional or physical stressful event, most often identifying in the preceding days. It commonly mimics as an acute MI in presentation. It is also known as apical ballooning syndrome, broken heart syndrome, stress-induced cardiomyopathy or ampulla cardiomyopathy. This term was the first described in Japan in 1991. Takotsubo is basically a Japanese pot which was used to trap the octopus. So basically in Takotsubo cardiomyopathy there will be octopus trap appearance of LV apex, which is apical hypokinesia with basal hyperkinesia. If we look into the epidemiology, 1 to 2% of patients with Takotsubo cases are misdiagnosed as ACS. It occurs more frequently in postmenopausal women because of decreased estrogen levels, increased sympathetic drive, endothelial dysfunction, which leads to the predisposition to microvascular dysfunction. Emotional and physical stress are triggers for the stress cardiomyopathy. Recently, it has been also described in the patients who follows unexpected pleasant events. So it is also known as happy heart syndrome. Main three triggers are emotional stressors, physical stressors, and central nervous system disorder. Emotional stressors include the death of loved ones, assault and violence, natural disasters, great financial loss, with most involving a sense of doom. Physical stressors include acute critical illness, surgery, severe pain, sepsis, and exacerbation of COPD or asthma. And CNS disorders include seizures, ischemic or hemorrhagic stroke, encephalitis, meningitis, head trauma, and Prace syndrome. Risk factors, mainly it commonly involves the female due to the decreased levels of estrogen. In 10 to 25% of patient, diabetes is associated. It is associated with increased mortality. Neuroautonomic nerve remodeling is seen in diabetic patient and asthma exacerbation. Cannabis use because of neuropeptide Y expression in the acute nucleus, arcuate nucleus in the hypothalamus, subarachnoid hemorrhage and ischemic stroke. Intense endocannabinoid production leads to neurocardiogenic myocardial stunning. And serotonin, norepinephrine reuptake inhibitors, and during serotonergic syndrome, catecholamine storm can lead to subsequent ventricular dysfunction. So if we look into the pathophysiology, there will be emotional stressors, physical stresses, and risk factors. Risk factors, as we described, female sex, post-menopause, schizophrenia, anxiety, depression, which eventually lead to the expression of neuropeptide Y in the hypothalamus and pituitary, which will have direct cardioinhibitory effects and acute microvascular dysfunction, and it will lead to the development of stress cardiomyopathy. So if we look into the pathophysiology, intense sympathetic activation and elevated circulating catecholamine levels are the main responsible factors for the development of Takotsubo syndrome. The catecholamine levels are substantially elevated in patient with TTS, up to 3 times higher than normal in patient presenting with acute MI. TTS has also been reported in many patients as a cardiac complication of pheochromocytoma. Iatrogenically administered catecholamines, mainly epinephrine, dobutamine, and beta adrenoreceptor agonists like salbutamol have been documented to directly trigger episodes of Takotsubo. So subarachnoid hemorrhage, pheochromocytoma, reduced presynaptic norepinephrine reuptake by the SSRIs, inhaled beta-2 agonist, intravenous epinephrine are main responsible. Abnormality of central autonomic nervous system has also been described. It has been found with the development of functional MRI. Brain scan has showed reduced antroventral cortical thickness of the insular gyrus and reduced amygdala matter volume. What are the consequences of high circulating catecholamine levels and enhanced sympathetic stimulation? It leads to the dysfunction of coronary microcirculation and microcirculation both. First of all, Sato described that a case of TTS in 1990. He proposed that microvascular dysfunction and coronary artery spasm are the cause of TTS. Later, it was reported that impaired coronary perfusion and severe myocardial metabolic abnormalities are found in patients with Takotsubo on thallium scan. Direct effects of high catecholamine levels on cardiomyocyte function. Transient LV dysfunction has been described due to the direct effects of catecholamines on the ventricular myocardium, which are known as neurogenic or catecholaminergic stunning. Results from calcium overload, ROS production and mitochondrial dysfunction has also been described. Why Takotsubo commonly involves the apex? Because beta 1 adrenoreceptor and beta 2 adrenoreceptor density is highest in the apex. Sympathetic innervation is highest at the base and lowest in the apex, which suggests that apical myocardium may be more sensitive to high levels of catecholamines. Although epinephrine is a positive ionotrope at low and modest levels, but at high levels, epinephrine exerts a negative ionotropic effect. Inflammation has also been described in the pathophysiology of Takotsubo. If myocardial inflammation persists in the subacute and chronic phases, it may be contributing to the long-term cardiac dysfunction and symptoms which rarely are observed in Takotsubo. There are examples of Takotsubo cases triggered by the influenza vaccination and also by the immune checkpoint inhibitors for cancer, which suggest it is possible to trigger Takotsubo via immune activation and inflammation. So, if we summarize the mechanism which are involved in the pathophysiology of Takotsubo, there will be central sympathetic storm, there will be acute surge in ventricular afterload, peripheral sympathetic storm, which ultimately will lead to the development of multivessel spasm, activation of negative ionotropic signaling by catecholamines working at the beta 1 adrenoreceptor and beta 2 adrenoreceptor, and microvascular dysfunction. Inflammation, nitrosative stress are the other pathophysiology. This is also the summary of the same. So now we will look into the types of Takotsubo cardiomyopathy. Briefly, they are divided into 4 parts: typical, reverse, midventricular and localized. Typical Takotsubo cardiomyopathy involves the apical ballooning with hypercontractile base. Reverse Takotsubo is described as basal akinesia with hypercontractile apex. Midventricular Takotsubo in which there is midventricular hypokinesia with apical and basal hyperkinesia, and localized may involve any part of the myocardium. So these are the angiocardiograms. Look carefully in the end systole images. In the first image there is classical apical ballooning. In the second image there is mid-cavitary involvement, and third and fourth are basal and focal Takotsubo syndromes. So these are the anatomical variants of stress cardiomyopathy. Most common is apical ballooning, which has prevalence of 75 to 80%, and it can be associated with alveoli obstruction and apical thrombus formation, and it has variable prognosis. Commonly it resolves in 2 to 3 weeks. Midventricular variant has 10 to 20% prevalence. Patient develops severe left ventricular dysfunction in these cases, and acute heart failure presentation is very common. Basal is less common, 5% cases are observed in basal, less severe hemodynamic compromise, and biventricular and focal dysfunction is less than 1% cases, and focal dysfunction generally has benign course and more commonly associated with the chest pain. So in 2014, Mayo Clinic gave the criteria for the diagnosis of Takotsubo cardiomyopathy. It includes the 4 criteria, and all 4 criteria must be fulfilled. First one is left ventricular wall motion abnormalities, which may be in the form of transient hypokinesia, akinesia, dyskinesia extending beyond a single coronary segment. Absence of coronary stenosis, which is described as more than 50% obstruction, or no evidence of acute plaque rupture on angiography. New ECG abnormalities or remarkable increase in cardiac biomarkers, and absence of myocarditis or pheochromocytoma. Heart Failure Association and International Takotsubo diagnostic criteria has also been given by the 2 different society. If we briefly look into the Intertek diagnostic criteria, there are 8 criteria basically. First one is patient shows transient left ventricular dysfunction in the form of hypokinesia, akinesia, dyskinesia, and emotional, physical or combined triggers should be present. Neurological disorders may be the underlying cause. New ECG abnormalities are present like ST segment elevation, ST segment depression, QTC prolongation. Levels of cardiac biomarkers are moderately elevated but less than that which is observed in heart failure and MI. Significant coronary artery disease is not a contraindication. Patients have no evidence of infectious myocarditis, and postmenopausal women are predominantly affected. Now we will briefly look into the clinical features. Most common presentation is postmenopausal woman with acute or subacute onset of chest pain. More than 75% of cases presents with this presentation. Shortness of breath with heart failure is observed in approximately 50% of patients. Patient may present with occasional syncope or dizziness in 5 to 10% of cases because of LVOT obstruction. And on physical examination, commonly observed symptoms of heart failure can be found, like respiratory distress, tachycardia, hypotension, cold peripheries with narrow pulse pressure, S3 gallop, jugular vein distension, and rales at the bases of lung. Intertech diagnostic score has been given by the Intertech registry. 0 to 100 score is described, and there are 7 criteria in Intertech diagnostic score. Female has been given the maximum points, and QTC prolongation has been given the given 6 points. And if we add all the different criterias, if it is more than 50, the diagnosis of Takotsubo can be done with the specificity of 95%. And if the score is less than 31%, ACS is the diagnosis, and with the specificity of 95%. So diagnosis is basically on the clinical grounds, but other useful biomarkers, echo and ECG can be helpful. Cardiac biomarker levels like serum BNP and pro-BNP are almost always elevated, with higher levels correlating with the degree of ventricular wall motion abnormalities, and usually greater than those observed with ACS. The peak level of BNP is observed at 48 hours after the presentation, and with elevation can be found up to 3 months. Cardiac troponin levels are generally less than 10 nanogram per deciliter. So this is the differentiating factor with ACS. In ACS, we found much higher level of cardiac troponin, and CPK-MB levels are mildly elevated in Takotsubo. ECG, ischemic ST segment and T wave changes are found. ST elevation is more commonly found than ST segment depression. T wave inversion in the form of deep and widespread T wave inversion. Significant QT prolongation can be found, and torsades pointis has also been described in many patients of the Takotsubo. Usually, ECG changes develops after 24 to 48 hours after the onset of symptoms or the precipitating stressful trigger. 2D echo is the most important test bedside investigation or useful for the evaluation of Takotsubo. Regional LV wall motion abnormality beyond the single territory perfused by a epicardial coronary artery that is reversible in nature and is often associated with emotional or physical stress. A global LV akinesis or dyskinesis with a classic circumferential pattern involving the entire apex most commonly, or the mid-ventricular or basal segment with classical apical ballooning form. Apical ballooning is often associated with other suggestive features such as LVOTO obstruction due to the basal hypercontractility, and MR can also be observed due to systolic anterior movement of the anterior leaflet of mitral valve. So these are the classic echo images. In the figure A, there is a classical apical ballooning and Japanese spot appearance, and B is the recovery image after 2 to 3 weeks in patient, and there is clear cut resolution of apical ballooning in image B. Moderate to severe MR may be observed at the initial presentation, which will recover in most of the cases in follow-up. Mitral valve tethering can also be observed. Recently, cardiac MRI has been used for the diagnosis of Takotsubo. During the acute phase of stress cardiomyopathy, T2 weighted images shows the myocardial edema as high signal intensity in the acute phase. Absence or patchy microscopic fibrosis, as documented by the lack of delayed gadolinium enhancement, is a classic hallmark of stress cardiomyopathy. It helps to differentiate it from the ACS, where delayed gadolinium enhancement is always present. So these are the classical cardiac MRI images where 3 different forms of Takotsubo are we can see. In the image A, there is apical ballooning. In the image B, there is basal involvement, and in the image C, there is mid ventricular involvement. So, what are the differential diagnosis of stress cardiomyopathy? Myocardial infarction and myocarditis are the close mimics of the stress cardiomyopathy. Clinical presentation can be similar in all the three cases, but echocardiography, coronary angiography, cardiac magnetic resonance imaging, and biomarkers help to differentiate. In echocardiography in stress cardiomyopathy, as we described, there will be classical involvement of the apex. In myocardial infarction, there will be regional wall motion abnormalities according to the epicardial coronary artery distribution, and in myocarditis, there will be global systolic dysfunction. Coronary angiography helps to differentiate between myocardial infarction and stress cardiomyopathy. Coronary artery disease will be found with acute plaque rupture or thrombus formation in myocardial infarction. In myocarditis, we can find edema in subepicardial, basal, and lateral walls of myocardium in CMR. If we look for the biomarkers, NT-proBNP and troponin are mildly elevated in stress cardiomyopathy. Troponin and CPKMB levels will be significantly elevated in myocardial infarction, and BNP and NT-proBNP are significantly elevated in myocarditis. So, what are the complications of stress cardiomyopathy? Acute heart failure and cardiogenic shock. Systolic heart failure is the most common complication in the acute phase. It is secondary to complications such as LVOT obstruction and MR. In the absence of complication, the echocardiogram shows severely reduced stroke volume due to a reduced LVEF in non-dilated left ventricle. LVOT obstruction is a common complication. In the classical apical ballooning, what happens, there will be hypercontractility of the basal LV segment, which will lead to the development of LVOTO, and mitral valve systolic anterior motion due to Venturi effect, which ultimately leads to the development of MR. Arrhythmias are commonly associated and can be the initial presentation in patient with Takotsubo. Atrial fibrillation has been reported in about 5 to 15% of patients, and it is most commonly associated with lower LVEF and higher incidence of cardiogenic shock. Ventricular arrhythmias occur in 4 to 9% of patients during the acute phase, and torsades pointis complicating stress cardiomyopathy is observed in the setting of QT interval prolongation more than 500 milliseconds. Systemic thromboembolism has also been described due to the LV thrombus formation, especially in its apical forms, which can lead to embolization and stroke. Intramyocardial hemorrhage and rupture can also occur due to the reperfusion injury. There is another terminology which has been described like stress cardiomyopathy in young individual. If we look into the epidemiology, it is generally rare. Takotsubo is generally rarely found in age younger than 60 years. Less than 10% cases are described in age less than 55 years and less than 2% in age less than 35 years. Comorbidities are commonly seen: schizophrenia, anorexia. Triggers like pregnancy, medications like drug abuse, catecholamine use. Anatomical pattern is more often atypical forms like basal and mid-ventricular form, and prognosis is grave in young individual. There is high risk of arrhythmias, hemodynamic instabilities, and greater propensity for recurrence in future. Now we will, in the end, we will look for the management of Takotsubo cardiomyopathy cases. Basically, management is in the form of supportive management. We have to manage the heart failure, we have to manage the MR, LVOT obstruction, and manage the arrhythmias. ECG monitoring is very crucial in the management of Takotsubo cardiomyopathy. Admission to an acute cardiac or medical unit with continuous ECG monitoring, given there is high risk of arrhythmias, particularly in the setting of prolonged QTC. In the absence of QTC prolongation or arrhythmias, monitoring for 48 hours is generally considered sufficient. So, patients with Takotsubo should be admitted in critical care unit where there is LV ejection fraction is of more than 45% and no LV dysfunction. Patient can be safely observed and early discharge can be planned. But patient with severe LV dysfunctions, patient with arrhythmias, apical thrombus formation, and patients with cardiogenic shock requires close monitoring, and another forms of mechanical circulatory supports may be required. Treatment of heart failure, relief of congestion, and hemodynamic support in cases of low cardiac output state. It is essential to determine the pattern of cardiomyopathy and the presence or absence of LVOTO, which is usually obtained through transthoracic echocardiography. For patients with pulmonary congestion and without hypotension or signs of low cardiac output, the treatment is aimed at reducing the venous return with venodilators, classical venodilators like nitroglycerin, nitroprusside and nesiritide, and with diuretic agents. This is basically symptomatic management of heart failure. Arterial vasodilators should be used cautiously in patients with hypotension. If patient present with systemic arterial hypertension, they can be safely used, but it may worsen the LVOTO in patients with hypotension. Beta receptor blockers can be added to treat the hypertension in patients who are hemodynamically stable, and they may be particularly useful in cases with LVOTO, as they can reduce both the basal hypercontractility and may relieve the obstruction, and it also alleviates the anxiety of the patient. In the absence of obstruction, drug with positive ionotropic actions like dobutamine, milrinone, dopamine, levosimendan can be considered to increase the cardiac output. Bridge therapy, ionotropic agents are not sufficient. If they are not sufficient, vasopressor drugs can be used as a bridging therapy. Phenylephrine, norepinephrine, and vasopressin are used as a temporizing agent as a bridge to mechanical support with a left ventricular assist device or as a bridge to recovery. IABP with intra-aortic balloon pump and percutaneous left ventricular assist device like Impella are well suited to provide temporary support. Prevention of arrhythmias is very crucial. Treatment with beta blockers may protect against malignant arrhythmias and development of cardiac rupture. It prevents the development of polymorphic ventricular tachycardias like torsades. Prevention of thromboembolism is also crucial. Systemic anticoagulation should be considered in patients with large areas of akinesia and low ventricular ejection fraction. LMWH or heparin can be used. For those patients with thrombus formation, treatment is recommended for up to 3 months. Beta blockers in patients with increased sympathetic tone, ongoing cardiac symptoms, persistent anxiety or recurrent episodes. ACE inhibitors or ARBs showed a marginal benefit at 1 year survival. Calcium channel blockers have been associated with a shorter and faster recovery. Attention should be given to assessment for psychiatric problems and or substance abuse and underlying disorder that has precipitated the Takotsubo. And substance abuse may persist and contribute to the risk of recurrence and long-term outcome of Takotsubo. So, if we summarize the treatment algorithm for stress cardiomyopathy, we should divide the patient with who presents with cardiogenic shock or pulmonary congestion. Patient presenting with the pulmonary congestion without low cardiac output symptoms, they should be treated as systolic heart failure, and classical therapy with venodilators, diuretics, arterial vasodilators if hypertension, and beta blockers should be given. And if patient present with cardiogenic shock with the symptoms of low cardiac output, LVOTO should be considered in the management. If patient present with LVOTO, we should avoid the ionotropes because it will worsen the LVOTO and there will be worsening of the patient. But if patient present without LVOTO, supportive care is enough with the ionotropes like milrinone, dobutamine and dopamine. If patients are not managed with this supportive care, patient should be considered for mechanical circulatory therapy in the form of IABP or Impella, and supportive therapy with like anticoagulation should be considered. Prognosis is generally very good in patients with the Takotsubo. It has an in-hospital mortality of up to 5%. Most in-hospital deaths occurred among patients with unstable presentation who are presenting with cardiac arrest secondary to polymorphic ventricular tachycardia or cardiogenic shock. Recovery of LV contraction is generally gradual, generally occurring over a period of 1 to 2 weeks. Although the process may be rapid within the 48 hours or it may be delayed till 6 weeks. Recurrence are common, generally 2 to 4% per year and up to 20% at 10 years. Even after complete recovery of left ventricular ejection fraction. It is commonly observed in patients who continue to the substance abuse and there is continuous precipitating event is present. TTS patients have increased prevalence of anxiety disorder as a form of post-traumatic stress disorder. Thank you.